A very good afternoon to all. Thank you, Nagin sir and AIOS for giving me this opportunity. So, going from the organic causes to the functional causes now.
नहीं है लोड किया हुआ है.
Can we have the slides? Lens changes like this cannot be missed by anyone. But this patient, a 48-year-old farmer female, came with a complaint of blurring of vision in left eye, which she was not happy with. Slit lamp examination of right eye was normal and left eye showed a dot posterior polar cataract. So the subtle cataract can also be in the center in the visual axis can also be a cause of loss of quality of vision. This 15-year-old male boy complaining of gradual blurring of vision in both the eyes. This child was on dialysis weekly for chronic renal failure. He was a case of myopic astigmatism, and patient's parents were actually of the opinion that because of some reasons he is going in depression and he's trying to find ways out to avoid going to school. But when we did the examination, the oil droplet appearance clinched the diagnosis of lenticonus. There was a scissoring reflex on retinoscopy, and this lenticonus with early capsular cataractus changes was seen. Now coming to the functional visual loss. Functional visual loss or non-organic visual loss by definition is a subnormal vision where no underlying pathology of visual system can be found. Something is out of place here. It's actually a clinical diagnosis and it may be seen in the continuum from frank malingering to hysteria. The diagnosis relies on the high index of suspicion. The financial burden of evaluation and potential disability related claims nowadays may be substantial. The aim of this part of the IC is to provide a practical approach to examination of patients with suspected functional visual loss. How to approach a case? In these cases, our aim is to demonstrate that the person has a better vision than alleged. Again, a high index of suspicion where the clinical signs and symptoms do not match. It can be bilateral or unilateral. Subjective and objective tests should be carried out, and it should be carried out swiftly and confidently. There can be some reasons organic also. There can be some cataract. Early cataract can't explain a vision of 660. There can be some disease organic pathology with a superimposed functional component which is making out of proportion loss of vision. Organic causes can also masquerade as functional visual loss, like as Nagin sir has pointed earlier, occult retinal dystrophies, Stargardt dystrophy, CAR, MAR, cortical visual impairment, inherited optic neuropathies. Of occult retinal diseases, maculopathies, paraneoplastic syndrome, vitamin A deficiency, white dot syndromes are to name the few. Whenever we talk about chloroquine maculopathy, the first thing which comes to our mind is bullseye maculopathy. But in early cases, it might not be obviously evident to us. The vision loss in paraneoplastic syndromes is due to the reaction to original cancer that affects the retinal cells, photoreceptors, leading to loss of vision. In cancer-associated retinopathies or melanoma-associated retinopathies, electrophysiological testing is the investigation of choice. And we see different zones and depression right under the center. When we have a case which we suspect as functional visual loss, we want to exclude the subtle causes. Electrophysiology is our friend here. Make sure to order both ERG and VEP together, and this little table is going to guide us. Like if a patient has a normal vision, both ERG and VEP is going to be normal. While if a patient's ERG is abnormal and VEP is normal, that means there is some pathology in the retina. While if the ERG is normal and VEP is abnormal, we expect the pathology to be somewhere in optic nerve or beyond. Examination of a non-organic visual loss case starts as soon as the patient walks inside the room. A truly blind case will walk cautiously, avoiding any furniture or hitting anybody. But a malinger knowingly bumps into them. The test should be performed, all tests, whatever we do, should be performed very smoothly and confidently, and the patient should be taken into confidence. A patient walking into a clinic with sunglasses on is reported as a strong predictor of non-organic vision loss, provided the patient does not have any particular indications such as intense photophobia or acute migraine attack. Finger touching test is a subjective test. Actually, it can be done in patients complaining of profound vision loss, and we suspect a functional case. Because we know finger touching is actually a proprioceptive test. It is not testing the vision. But because we know the physiology better than the patient, we can ask the patient to close the eye or to touch both his fingers together. A malinger usually tries to overshoot. OK and drum elicit optokinetic nystagmus in viewer's eye. And the routine, if a patient even is not able to see anything, ask him to focus towards the OK and drum. It induces smooth pursuit and then refixation saccades. It is helpful in hand motion or worse cases. If we are able to elicit the nystagmus with OK and drum, we establish a vision of at least 20/400. Another reflex is mirror reflex. We can distract the patient by holding a conversation with them and use a mirror that is moved across the field of vision. It is difficult for a patient to resist looking at their own reflection and following the moving image. Pupillary reflex, Dr. Anita has very well explained. It is positive in cases with optic neuropathies or severe retinal pathologies. Definitely, you can have normal pupillary reaction in cortical blindness cases. Signature test is again one subjective test, again a feature of proprioception, but a patient who is trying to malinger usually tries to scrib. Stereopsis, we all know, is a feature of binocular vision. Titmus or Randot test can be performed, and it requires a particular minimum level of vision to correlate to the degree of stereopsis. In monocular vision loss, we can blur the seeing eye with a high power convex lens and ask the patient to continue reading. Just make sure the patient's both the eyes are open and he doesn't understand that you are trying to actually assess the bad eye. It can also be done using a combination of plus minus lenses, which is equivalent to plain glass. Based on the principle that the colored lens allow only similar colored light to pass through it. If a patient is made to use red-green glasses and shown this acuity chart, and if he is able to read the entire chart in red and green, that means he has good vision in both the eyes. Usually in malingers, we have a clover leaf type of pattern in perimetry because they deliberately try not to click and they give a falsely negative errors. Prism shift test is an important test in which we close the bad eye and try to induce diplopia in the seeing eye by splitting the pupillary area with a prism. If a patient has no vision in left eye and we, while talking to the patient, we induce diplopia in right eye, and gradually we remove the other eye, hand of the other eye, and if the patient is not having no vision in that eye, he won't be able to see any diplopia. He won't be having any diplopia. But if a patient is malinger, the diplopia will still persist. So the management requires an understanding approach. Confrontation is seldom helpful in such cases. It is important to stress to the patient that functional visual loss has a good prognosis, and thereby we are providing a way out, giving the patient the opportunity to recover. So a careful history and examination with a healthy index of suspicion, care of occult visual loss, consider electrodiagnostic testing. In functional visual loss, we demonstrate better eyesight than claimed. I'm sure many of you will be able to read the letter written in this image. It's LIAR. As we say, har jhoot bura nahi hota. Not all liars are bad. We have to give them suggestions, motivation, and encouragement. At times, we need repeated and frequent appointments to build trust and confidence in the patient and suggest potential for improvement. This helps to reduce the doctor shopping and multiple unnecessary testing. Thank you for the attention.